So today I'm going to be talking about renal nutrition practices in outpatient dialysis. Currently, I am a regional lead in work for Davita Kidney Care based in New Jersey. So what are the normal healthy kidney functions? Normally, kidneys removes the waste products and also removes the fluid. It also helps in a red blood cells production. It helps to regulate the blood pressure and it helps to maintain the bone health by bone producing active vitamin D and thus helping in bone mineral turnover and metabolism and mineralization. It also helps to maintain the acid-base balance. However, due to various reasons, the kidneys can fail and it can go in a acute kidney failure or chronic kidney failure. Acute kidney failure can be sometimes reversed using the steroids, and usually it's reversed within first 3 months. Versus chronic kidney failure, by definition, it's defined as the abnormalities of kidney structures or functions which is present more than 3 months, and it could be present with the implications for health. CKD is generally classified based on what caused the disease, what stages are in the disease. It could be stage from 1 from 5, and the presence of albumin in the urine. It is commonly abbreviated as GCA. So these are the stages of kidney disease from stage 1 to 5. And today I will be covering mostly the stage 5, where the kidney failure is actually mostly irreversible and the GFR has dropped below 15 and the patients are on dialysis. And that's my primary goal. I take care of dialysis patients. What are the causes? The primary causes includes diabetes, blood pressure, glomerulonephritis, cystic kidneys, and there are unknown or other reasons. For example, lupus can also cause the kidney failure. Now, what can we do for the prevention? So when the patients are in stage 1 to 4, and if there is a presence of diabetes, we should be, number one, should be the type diabetes control by checking their hemoglobin A1C. For American Diabetic Association, the A1C needs to be checked at least twice a year if it's controlled below 7%, if not, much more frequently, along with the checking the cholesterol levels, the serum creatinine, the presence of albumin in the urine, and the dilated eye exam. And that is also the mission statements for one of the mission statements for Healthy People 2020, the program by the government for the prevention. Now, there are 3 types of dialysis I usually deal with. First and most common is hemodialysis. It is generally done 3 times a week. The patients comes in center. They are hooked to the machine that I've shared on the right-hand side of the picture. That is a typical dialysis machine. And the treatment length for each dialysis is 4 hours average per patient. And as I said, usually 3 times a week. And the treatment is, and the nursing and the technicians are the one performing the treatment. Second is the peritoneal dialysis. So in that, the catheter is inserted in patient's peritoneum right below the navel. And the patient is given the training, and usually the training lasts about 7 days by a registered nurse. And then the patient is discharged home to do the treatment on their own every night. Every night, the patient is hooked to a cycler. The cycler is the size of a suitcase where, with the help of a cycler, the PD fluid is infused in the peritoneum, and then it is left there for about 2 hours. It's called dwell time. And then at the end of the dwell time, the fluid is removed and it's discarded. Certain 5 or 6 cycles, depending on the patient's body weight and prescription and the kidney damage, it's prescribed for individualized patient. It has done 7 days a week at home, and there is no blood involved. The third thing is home hemodialysis. So this is also hemodialysis done at home by patient along with a care partner. It is also 3 to 4 hours treatment, but compared to that, it's much more gentler. And it mimics having a natural kidneys, because our kidneys work 7 days a week. There is no weekend for kidneys. So it's the same thing for this. What are the effects of dialysis on blood levels? So usually when the patient undergoes a treatment, the dialysis removes the waste products from the blood. It is usually blood urea nitrogen, creatinine, which is built up in the patient's blood, and it's not removed by normal kidneys. Dialysis helps to remove that, along with potassium, phosphorus, fluid, and along with the removal of waste products, protein is also lost. There is absorption happening there with the addition of bicarb level and also the calcium. There is a difference, concentration of albumin and sodium also is changed due to removal of fluid. So National Kidney Foundation has developed guidelines. It's called Kidney Disease Outcomes Quality Initiatives. These guidelines are developed for the clinicians to improve the quality of care and outcomes of kidney disease patients. And I've also and there are also guidelines by American Dietetic Association. Based on the guidelines, each dialysis facility, they develop their own individual guidelines. But generally, when the patients are admitted in the dialysis clinic, there is an initial nutrition assessment is performed, which is performed within first 28 days or the first 13 treatments, whichever comes the later. In the initial nutrition assessment, the objective data and the subjective data is collected. Objective data includes the diagnosis, the history, the anthropometric measurements, what is the actual patient's urine output, which stage. Some patients, when even they are on stage 5 kidneys, they still have some urine output left. So based on that, what medications are they taking? What are the labs? What are the social and physical factors? Those information is collected along with how is their appetite? What is their intake? What background they come from? So depending on their food preferences are collected, and the nutrition education is provided to each patient based on that. The renal diet education is provided, and along with the labs are reviewed for each and every patient every month. Along with that, every patient is educated on an emergency diet guideline, such as if there is any disaster and patient cannot do the dialysis treatment, they need to restrict their diet much more. They need to watch what they're eating much more carefully, because that there is no dialysis happening for the removal of toxins. And also, if the patient's eating up, because these patients are also having a normal life along with their dialysis treatments 3 times or 7 times a week, they're also eating out. So they're also educated how can they safely eat out while maintaining their renal diet restrictions. Every patient also have to have a documentation by clinician, by dietitian. So specific nutrition education and how it was given, the mode of education. Was it a telephonic? Was it in person? Was it via the extended care facility such as nursing home? Was the significant others present? They all part needs to be documented in a timely manner. And the individualized care plan has been developed, should be developed, I'm sorry. Now, what are the biochemical parameters? What are the labs we measure for each and every patient? The number one is albumin. As you all know, albumin is a protein in the blood. Albumin is the lower levels are associated with higher risk of infection, hospitalization, and mortality risk. KDOQI goal is, the normal person's goal albumin is 3.5. For dialysis, KDOQI recommends 4.0. The causes for low albumins could be inadequate protein intake, could be higher protein losses, such as in peritoneal dialysis, infection, fluid overload, liver disease, pica, malabsorption, nephrotic syndromes, cirrhosis, etc., etc. The dietary protein intake for hemodialysis patients should be individualized based on, and usually ranges from 1 to 1.2 grams per kilogram of ideal body weight per day. Versus for PD, it is much higher because the losses are much higher as the patients are doing daily dialysis, and it can range up to 1 to 1.4 grams per kilogram ideal body weight. The common foods in high protein are encouraged, along with sometimes the protein supplements are used. They could range from oral supplements to enteral, and if needed, the interdialytic parenteral nutrition is also recommended if all the previous treatment fails. The next thing is phosphorus. Phosphorus is the most commonly found mineral, and it's mainly present in the bone and teeth. The goal for the phosphorus restriction is 800 to 1,000 milligrams per day. If the phosphorus is not controlled, the persistent hyperphosphatemia cause itching, bone damage, and calcification. Therefore, diet education to restrict high phosphorus foods such as dairy products, dark soda, chocolates, beans, processed food is recommended. And if the diet cannot alone help, the phosphorus binder medication, which we call binder in a common terms, is prescribed. That needs to be taken by patient with each and every meal. The next is calcium. The goal for calcium is 2,000 milligrams per day by Kedoki. The hypercalcemia is the biggest risk for the patients who are on dialysis because of the risk of calcification of softer tissue, and it also increases risk of heart disease. The dietary sources for calcium includes the fortified foods, the dairy products, and sometimes the patients are also taking calcium supplements on their own over the counter. That also can increase the risk of calcium levels in the blood. And also, depending on the calcium level in the blood for the patient, we have to decide whether the calcium-based binders for phosphorus are used or not. Also, the vitamin D dose is being titrated every month based on the calcium level. Sodium and fluid, the most common challenge for each and every dialysis patient. The sodium intake is usually recommended by Kedoki's 2.4 grams per day, but we try to aim for 2 grams per day as it's widely, easily available, and it's most difficult to control. And the fluid restriction is individualized for each patient based on their urine output and their interdialytic weight gains. As we all know, high sodium can cause hypertension, coronary vascular disease, and the causes of the sodium and fluid imbalance could be whether they are taking high sodium in their diet, what is the hydration status, whether they miss the treatment. That can also lead to fluid accumulation, whether their urine output has changed, and that's also typical when the patients start dialysis, eventually their urine output goes down. So as the output goes down, we have to go much more in fluid restriction. We have to educate patients. We have to closely monitor how it's declining and whether they have ascites. What is their glycemic control? If the sugars are not controlled, that can also cause the thirst. That can lead to higher fluid gains. And certain medication also causes. So we have to really dig into what is actually causing the imbalance and then educate them. Mineral and bone disorder management. It includes mainly maintaining the calcium and phosphorus levels to control the parathyroid hormone. How can we do management? It needs dialysis, number one. The diet, renal diet, plays a very important role by controlling the phosphorus and calcium intake to maintain the parathyroid levels, and additional treatments such as the use of phosphorus binders, use of vitamin D, the active form of vitamin D such as calcitriol, and use of calcimimetic agents. Anemia. CKD patients have predispositions to anemia as kidneys are involved in the red blood cell production, the normal kidneys, and in dialysis, the RBC lifespan is reduced by half. So it is the most prevalent there, and the dialysis patients are mainly dependent on either oral or IV by iron to maintain the adequate serum iron, depending on their ferritin level and their TSAT level. And it is also usually checked twice a month, sometimes 4 times a month, depending on where they belong. And the dose is titrated along with the physician's prescription. Dialysis adequacy. It is measured every month on every patient by measuring URR, urea reduction ratio, and KT over V. It's called their clearance. It indicates how effectively each patient's blood is clean from the waste product. As I mentioned, this is done on every patient every month. If the patients are not meeting the goal, we have to identify what factors are affecting the clearance. Either they have a problem with their access, then the surgeon needs to look at the access. If there is a problem with the blood flow rate, then we need to adjust the blood flow rate, dialysis flow rate, the needle size, the treatment time, whether they need more treatment on the machine, whether the 2 hours, 3 hours is not adequate. Then we need to come up with a plan. We do have to have intervention, and we have to make sure the patients are meeting their adequacy. The next thing is bicarbonate. Dialysis patients are usually prone to acidosis because, again, the kidneys are not working, and it can cause a low albumin and bone metabolism. So the acidosis is usually corrected by adding bicarbonate in the dialysis, and dialysate, and the goal is more than 22 milliequivalents per liter. And if the patient's acidotic, they are not hungry. If they're not clearing, they're not hungry, and they can lead to malnutrition. And these are the usual parameters we measure for each and every patient. I just gave you the overall overview of dialysis patients' labs. And, if anybody needs any much more detail, feel free to reach out